Brian's in Italy.
Oh, yeah, that's right. Brian's
Oh my
Sicily.
God.
No, he's not. He's in Sicily.
Where are they?
Sicily.
Oh,
It's not the same, apparently.
We are live.
Okay.
Thank you. Hi, Diana. Thank you for joining us today. We're really interested to hear your thoughts around this bill that we were just introduced to yesterday, S-142. And thank you for being with us.
Thank you so much. Thanks
You
to
can
all
go
the
ahead.
committee for inviting me. I have been asked to do 3 different testimonies altogether. And so
Okay.
the first one is regarding wording of the bill. There are a few recommendations that through meetings that I've been in have been made that I wanted to share. The second is my own personal testimony of my work over the past 3 years. It's been a long time, the past 3 years on S-142. And then the third is I would like to share 5 anonymous testimonies from internationally trained physicians that would like to practice in Vermont. So please tell me, just advise me, would you like me to do all 3 together? Or would you like me to stop after each one and maybe you might have some questions?
Yeah, stop after each one. And can I ask you, before you go into the recommended language changes, you indicated that you've been working with others. Has our legislative council been present with those? Unfortunately, she isn't able to be with us today. So usually when people have language changes, I'm like, where's leg council?
Well, she, and of course I can do it at a separate time if that's more convenient, but Representative Burbeco was meeting with her. Is her name
Okay.
Jen?
Yeah, Jen. Okay,
Yes,
great.
right. And
Great. Just wanted to make sure our ledge council was.
yeah, they
looped in.
wrote me yesterday and asked me to put in a little more formal way a testimony regarding those changes. So
Perfect. Thank you.
That's the first one. But yes, Jen has been involved.
Okay, great. Thanks so much. You can go
Okay.
ahead.
So I'll start with that. At your request, I'm sending my recommendation. Excuse me?
And our ledge council just walked in the room, Jen.
Oh, this is great.
Yeah.
Would you
can
like
go
me to
ahead.
continue?
Yes, please continue. Thank you.
At your request, I am sending my recommendations for improved wording of S-142. Number 1, in the new amendment, section 4B, change Vermont chapter of the NAACP, which is the way it's presently worded, to the Windham County NAACP. There is no statewide chapter. We collaborate regularly with the Rutland area branch of the NAACP. However, all of our advocacy for S-142 has been done by the Health Justice Committee of the Windham County NAACP. So that's the first. The second is regarding workforce authorization and comes out of recent meetings with World Education Services and Dr. Katie Wells. We realize that workforce authorization needs to be defined, and it's an oversight in S-142. New wording.
Do you have a provision number or a page number on that one so we can see what you're talking about?
Well, workforce authorization does not now exist.
It's not in here? Okay.
But,
okay, thank you.
But the new wording can be inserted in section 1391, qualifications for medical licensure, or section 1426, provisional license to practice with supervision. We want to stay true to the purpose of this bill and ensure the pathway is available to ITPs, and those are internationally trained practitioners, physicians, ITPs residing in Vermont or the United States at the time of application. Other states have included such language in their bills in a variety of ways. When looking at other bills, we find that the language used in Wisconsin might be the most comprehensive. So we just cut and paste what Wisconsin, the sentence that Wisconsin has. So that is, the applicant has or will have, prior to working as a physician in this state, a federal immigration status and employment authorization that enables the applicant to work as a physician in this state, unquote. Please note, the use of future tense recognizes current federal processing delays and allows individuals with pending work authorization to begin the licensure application process while waiting. This language is not intended to allow applications from individuals residing outside the United States. So that's on workforce authorization. The next and the last idea or proposal has to do with listing a better, dependable, universally recognized accreditation resource. So our present wording, which is in, you'll see it in 14261A, the applicant has received a degree of Doctor of Medicine or its equivalent from a legally chartered medical school outside the US that is recognized by the World Health Organization or the Foundation for the Advancement of International Medical Education and Research, or that appears on the official list of medical schools recognized by the Medical Board of California. So that's what's stated now. This is the recommendation. There is no single global accreditation authority that exists for medical schools worldwide. Therefore, we recommend that the bill relies on the World Directory of Medical Schools. This is the same list that determines eligibility for Educational Commission for Foreign Medical Graduates, ECFMG, certification and associated credential verification, and would therefore create synergies in the licensure process for internationally trained physicians. So those are the three recommendations. In closing, I just really recommend that your committee invite Dr. Katie Wells to testify. She's a member of the Consortium of Universities for Global Health. She's been really helpful in recent conversations, and I think she would expand on these ideas, but also others.
Thank you. Do we have contact information
Yeah.
okay, we have contact information. Thank you.
Great.
Any
So if you have any questions.
Yeah, any questions on these recommendations, or should we go into the next part of your testimony? All right, I guess.
Okay. So this is my personal testimony. I write you in support of S-142 and advocate for qualified internationally trained physicians to use the supervisory model pathway to return to practice in Vermont hospitals, FQHCs, and community health centers where they are most needed. I represent the Windham County NEACP Health Justice Committee, and these are our desired outcomes: reduction of Vermont healthcare workforce shortages, creation of clear pathways for internationally trained physicians currently in Vermont or in the US to enter our local healthcare workforce, and lastly, increase culturally sensitive medical practice through supporting more diversity in our healthcare workforce. I want to say, going forward, just a shout out to my colleague who I know is listening in, Ruth Steinmetz from Winooski, who has just been such a dedicated member of our Healthcare Health Justice Committee at the NAACP, and she's contributed to every aspect of this work. Please note, going forward, as recommended by the Advisory Commission that is part of the Federation of State Medical Boards, that we're using the term ITP, internationally trained physicians, in place of IMGs, which has been in the past such a common acronym. During 2025, we spread the word about the S142 bill on social media to internationally trained physicians living in Vermont and nearby states. We received 23 responses. 16 of those 23 agreed to 1-hour interviews with me, which educated us about their hopes and challenges for relicensing. Those interviewed came from Afghanistan, the Democratic Republic of the Congo, the DRC, the Republic of the Congo, Egypt, Sri Lanka, Trinidad and Tobago, and Canada. 13 of the 16 interviewed live in Vermont and have been for a while. The additional 3 would move to Vermont if the pathway is implemented. All were in full support of the bill. However, the bill's requirement on recency and length of practice are a significant challenge. Only 4 of the 16 presently meet the 3 out of the last 5 years stipulation. By the time they successfully take their required USMLE 1 and 2 exams, none of them will be eligible. Take a drink here. The 3 out of the past 5 years restriction has become a significant barrier limiting access to highly skilled ITPs who are ready to serve. Learning from states in our region which have implemented similar bills with longer recency provisions leads us to propose changing the existing language to at least 1 year of practice within the past 7 years. No ITP applicant can access this pathway without an offer of employment from a hospital, FQHC, or community health center in Vermont. Recent interviews with 6 Vermont hospital CEOs revealed their serious concerns about the unnecessary barriers to the recency and length of practice requirement reported in the Vermont bill at present. These barriers limit their ability to attract and retain ITPs to serve Vermonters. They strive to attract talent within Vermont and across state lines. Each institution's emphasis on patient safety ensures strong guardrails in the hiring process. They are willing to testify to propose more equitable guidelines to allow capable internationally trained physicians to join their medical teams. Changing the provision on the recency would give hiring entities access to a larger pool of talent. I add a note of appreciation here to Representative Berbecco for participating along with Senator Harrison in these CEO interviews. And I'd like to say that we have listed 4 hospital CEOs who are offering to testify to your committee. ITPs in Vermont are ready, willing, and able to serve patients in Vermont. 5 of the 16 ITPs interviewed have prepared brief written testimony, which I will be sharing with you. In closing, we share our brief, and I just sent the link in my letter, the link to our presentation. Ruth and I did a very successful presentation, attended well, at the 2025 UVM Health Equity Summit that was entitled Bridging the Gap, Integrating ITPs into Vermont's Healthcare Workforce. And it summarizes the disconnect we witnessed through these ITP interviews, the significant loss of primary care physicians in Vermont versus this untapped pool of ITPs who hope to relicense. So our NAACP is in full support of this new amendment to the bill, and along with other stakeholders, we welcome the opportunity to engage and learn from other states which have implemented similar pathways. So we're very grateful for the new amendment. Now I can go on to describe these 5 internationally trained physicians, but you might have some questions about my testimony first.
Any questions for Diana? No, thank you. And thank you for submitting your written testimony.
Okay. So I'll go on then. For personal safety reasons, these testimonies are anonymous. If there were different conditions in our larger world right now, each of these people would be coming to your committee personally. So this is, there are 5 different internationally trained physicians, and the first one is Dr. P.F. from Afghanistan, age 29. And his focus has been throughout his practice, being a general practitioner. He was highly well educated in the Zawal Institute of Higher Education, and then practiced for 3 years in Afghanistan before he abruptly had to leave. And in 2024, then spent a year in Pakistan and worked in a hospital there. So over a 3-year period, he reports his time in Afghanistan. He served over 3,600 patients each year. Presently, he is studying very intensely for the USMLE-1, and luckily he connected with, and part of it was through some support from Welcoming Communities programming. He got connected with an online USMLE network of mentors that are supporting internationally trained physicians to pass their USMLEs successfully. He's part of one of those groups. He has a P2 asylum 5-year work permit, and he's a green card applicant. Presently, he's employed at Brattleboro Memorial Hospital, and he began as a phlebotomist, and just in the last few months, he received an upgrade to working in the department for the operating room that sterilizes equipment. So that gives you a bit of his background. There's more, of course, in the written testimony. So number 2 is Dr. M.G. She's from Egypt. She's age 41, and her medical specialty is obstetrics and gynecology. She has graduated with honors from Cairo University, where she did her residency and later completed her PhD. Her career highlights are as a resident in the Department of Gynecology at Cairo University Hospital, and also working in the Ministry of Health Hospitals in Cairo. She's a combination researcher and practitioner. In her research world, she has done significant research at the National Research Center in Egypt, has also done research for 3 years in Tokyo on embryo implantation. She right now is intensely studying for her USMLE-1 and is receiving coaching from an Egyptian friend, a colleague, who just recently passed both the levels 1 and 2. In November 2024, she began a postdoctoral associate position at UVM in the Department of Obstetrics and Gynecology and Reproductive Sciences. She has recently published 1 research paper and is presently working on a second one. She has a J1 visa with a 2-year exemption approval. And in her testimony, she states that she wants to balance her career going forward with research and with practicing medicine in a clinic. She's dedicated to women's health. She's helped in the delivery of thousands of women, including serious C-sections, twin pregnancies, etc. She's dealt with many high-risk cases and finds that that's a necessary part of her life, as well as the research that she's doing that's similar to what she does at UVM. She has a talent to understand women's needs and is hoping to alleviate their suffering. Number 3 is Dr. A.S. from the Democratic Republic of Congo, and his specialty is a combination of general practice and neurosurgery. His career highlights include my training supported by the World Federation of Neurological Societies allowed me to master advanced neurosurgical techniques. After completing my 5-year residency in Zimbabwe, I pursued further specializations in France. He now returns to Zimbabwe annually and is a specialist consultant in neurosurgery at the University of Zimbabwe Medical School. His USMLE preparation is in process. He has a green card. His work in the US is as a medical interpreter. He lives in Essex Junction. He works as a medical interpreter. And he wants to express his strong interest in providing health care to refugees, immigrants, asylees, and other marginalized populations in Vermont. If he were licensed to practice as a general practitioner, it would impact him personally, but he thinks it would also improve quality of life in his immigrant community. I think this part of his testimony is important to share. I currently work part-time as a medical translator, assisting immigrants and refugees who struggle with language in medical settings. This role allows me to contribute to my community, but it's a small step towards my ultimate goal of practicing medicine again. As a translator, I often meet individuals when they attend medical appointments. Many of them struggle to express themselves, having spent years in refugee camps, which can lead to feelings of depression. I assist them in navigating the healthcare system. Most of my translation work comes from hospital requests, where I help clients understand medical terminology and communicate their needs. On the side, I often inform doctors about the cultural background that might influence the patient's health. I find fulfillment in supporting them, even in this limited capacity. So doctor number 4 is Dr. P.S. from the DRC, Democratic Republic of Congo, and he's aged 41. He is a general practitioner and was educated in general practice with an MD and a medical doctorate in surgery. He also has a master's degree in public health from the University of South Wales in the UK. And he now contacted me last week and let me know he's applying for a master's in public health degree at UVM. So he practiced in both the DRC and in Swaziland. And I'm just looking here, his responsibilities were internal medicine, minor and major surgery, outpatient maternity care, prenatal and postnatal care, et cetera, et cetera. I think what's important with this doctor is the high levels of administrative responsibility that he had. In the DRC, in the Lubumbo region, he was the head of the HIV and the TB department, and he supervised 10 clinics. He was appointed as the clinical lead for COVID-19 management at the main hospital. And he also became, in more recent years, the senior medical officer assisting cancer patients. So it's quite an array of skills that he demonstrated in all of these areas of work. He's beginning to study for his USMLE1, and he has an interesting position. I would say more highly skilled here in Chittenden County. He's working for a program called Collaborative Solutions Rehab in Richmond. And it was very exciting to him to not just be a phlebotomist, in other words, not just be at a low level in a hospital, but to, in a healthcare setting, to help people who are seeking treatment for mental health and co-occurring disorders. He is an asylum seeker and with a work permit. And in his testimony quote here, there's just a sentence I wanted to share. He's in my present position, supporting patients recovering from addictions, I can identify their medical issues, but I can't go further to help resolve them. I have the knowledge to do so much more, but in this country, no value is placed on my past education and experience. In addition to his work with rehab, he also is a medical interpreter with AALV. And then this is the final fifth doctor who submitted testimony to you. Dr. J.W., the Democratic Republic of Congo. He's age 47. His medical specialty is general practice and ophthalmology. He received high medical degrees and also, and this is in the DRC, but also a master degree of public health at the University of Vermont, class of 2019. His career highlights, I think some of you might even know this doctor. His diverse medical experience reflects a deep commitment to providing essential healthcare services to underserved areas. Up until 2010, in the DRC, he was a primary care physician in rural areas. And then he had a scholarship for a 2-year ophthalmology residency. From 2013 to 2019, in the US, his educational path included intensive English studies and a graduate certificate program in disability studies at the University of Vermont. He later earned a master's degree in public health from UVM in 2019, deepening his understanding of the American healthcare system and public health strategies, global health, and climate change. His employment in the US, he's worked in various healthcare roles. He's been a caregiver, a medication technician, and he's worked in Vermont's assisted living facilities. Despite his extensive qualifications, his attempts to secure roles aligning with his expertise have been difficult. His pursuit of positions at the Vermont Department of Health were not successful. He is a US citizen, and here is a short summary of what he has contributed to our Burlington area community. During the COVID-19 pandemic, he created a community radio show to provide public health education for immigrants. It continues today. This initiative expanded to include a monthly television program through CCTV, further broadening access to crucial health information. His media influence and expertise in immigrant health issues led him to a part-time job with the City of Burlington's Racial Equity, Inclusion, and Belonging program as a member of the Trusted Community Voices team, which serves as a bridge between municipal government and immigrant populations in Burlington. And in this way, he engaged Vermont residents in the region of Burlington from Bhutan, Vietnam, Congo, and Somalia. Since 2018, he has also been affiliated with the Larner School of Medicine at the University of Vermont, where he educates third-year medical students on cultural competency. He also shares his expertise with all of the medical students, helping to improve the effectiveness of medical services for diverse populations. He's also a founder and executive director of New Americans Public Health Initiative. So that is my summary. I hope I did these 5 extraordinary people justice, and I thank you so much for your time.
Thank you. Can I ask you a question about the last, Dr. JW?
Dr. JW?
So
Dr. J-
you,
J-
yeah,
it was
so you would,
J- yeah.
you had talked about, with recommendations around changes to the bill and working on the timing, with, length of time since not practice. And I'm kind of looking at the dates here. And even if we changed it to what you had, this
yes.
doctor would not qualify, correct?
That's right. And he knew that. He knew that what we were trying to do with the 1 out of 7 alternative proposed was that proposal came from the guidance of the World Education Services consultants. And I know that Mike Zimmer is going to testify at 11:30. We tried to be realistic and to use also what we had learned from the other, now it's almost 24 states that are enacting this similar type of bill. So he knew that he wasn't probably ever going to be able to license if that wasn't agreed to, if that 1 out of 7, but he still wanted his voice to be heard. And there are, I'm noticing in Mike Zimmer's testimony, there are certainly options to not have the out of the past so many years listed that he will explore.
Thank you. Any questions for Diana? Did you? Oh, Daisy, question?
Not a question, but just thank you for all of your work and all of the folks who are, I'm guessing, are listening, including Rose, and the doctors that shared their stories and continued to contribute to our communities in really meaningful ways, even though they are not operating at the top of their knowledge base. We're so lucky to have them. And as someone that represents Winooski, I can't tell you how incredible it would be to actually achieve the goal that I set out to do when I ran for office, which was have representation in healthcare for people in my community that that come from overseas. So thank you, Diana.
Thank you.
Diana, can I ask you about something that's in the bill that I sort of had questions about yesterday when we were doing the walkthrough? There is a piece that says essentially you would be ineligible for even beginning this lengthy process if you had lost a license, been suspended, anything like that, or had a criminal
Record.
And it doesn't specify like where that would have occurred. And I'm just, I was thinking about you said that the first person that you had to leave Afghanistan abruptly. And
Yes.
I was thinking about like political asylees that possibly would have been targeted criminally or with license revocation because of more political things from their country of origin.
So your point is that in the terms of
seems
that,
really restrictive.
yeah, and it's the perspective of that government, which might be condemning them for the political party they were part of or certain actions that they took, that would be on a record.
Yeah.
But it might not meet the types of questions we're asking about criminal behavior.
Yeah. And
so I think that's something to, first of all, I'm so glad Mike Zimmer is coming at 11:30, and I would like him to also address that, but I do think that that's not made clear in our bill the way it is right now.
okay. Thank you. And speaking of, I know we have Margaret.
Yeah.
Because we didn't think we had Mike until, can we continue with this conversation with, and then we'll move you to, okay, so we're gonna go to Mike Zimmer.
Oh my
Thank
gosh,
you.
that's great.
Sexy.
So thank you for your time.
Thank you. Hi, Mr. Zimmer. Thank
Hello,
you for
thank you.
joining us.
Thank you. I heard the tail end of that, so I think I know a couple things I have to address.
Yeah, that is, I just want to say that is quite the button collection you have.
I always tell the story. My grandfather, when he passed, left me his button collection that only had 6. It has now turned into sort of an obsession. And I try to hide it from my wife, but I'm not very good at it. By way of introduction, thank you, Chair and members of the committee. My name is Mike Zimmer. I'm a policy consultant at World Education Services, and we have been privileged to work with Diana and Ruth and her team in Vermont on this bill, and Senator Harrison, who is one of my new favorite legislators. WES is a nonprofit social enterprise dedicated to helping international students, immigrants, and refugees achieve their career potential. By way of sort of personal background, prior to joining WES, I was a licensing director and cabinet director in Michigan. So I've sort of bled licensing for probably 34 years of my career. So if I get too license geek on you, please tell me. As you know, the U.S. currently faces a significant shortage of practicing physicians. That is definitely true in Vermont. You are 115 FTEs below the national benchmark. In 2022, that's projected to increase to 370 FTEs by 2030. Since 2021, a number of states have explored legislative reforms to harness the skills and talents of internationally trained physicians. Legislation has already been enacted and is being implemented in 13 states. Further legislation has been enacted and rules are in process in another 7 states. To date, in 2026, legislation is now passed and is awaiting signature in Georgia, Kentucky, and Vermont, taking the total so far, if my math is right, to 25 states and territories. And there are 17 bills, including Vermont, that have been introduced this year. All of these bills create a provisional pathway license for internationally trained. We like to say this is not an immigration bill, this is a workforce bill. The model created in 142 would accomplish 3 critical things. Number 1, create a pathway for eligible previously licensed ITPs to work under the supervision of a fully licensed physician to meet the healthcare needs of the state's residents. Number 2, assist in reducing Vermont's healthcare work shortages. And number 3, increasing the cultural sensitivity of medical practice through supporting workforce diversity. It is important to note, and I think this question may have come up, a single accreditation bodies for medical schools around the world does not exist. As a result, we recommend, and I think you'll have an amendment to using the World Directory of Medical Schools, the same directory utilized by ECFM&G as part of their credential process. The legislation contains important provisions to assure quality care, requiring graduation from a program listed in that directory, requiring previous licensing, requiring prior significant history, ECFM&G certification, and a bona fide offer of employment from an eligible hiring entity. These provisions track those provisions in the other legislation going through. I would like to address for a moment a comment I heard at the end about individuals who may be caught in war-torn countries and have their licenses revoked at the time. My understanding, and I do not have the latest draft in front of me, is that the bill requires an individual to be in good standing at the time of their departure from the country. If that's not in the bill, it should be. Typically, what has happened in those countries is they may have their license, if they leave under duress, the medical licensing board may later take action against them, but that's after they've departed their country, if that makes any sense.
They wouldn't be subject to some sort of persecution while still in their country, which then would lead them to leaving their country?
They would, but the only test is, were they in good standing? Or did they have a criminal charge against them? I'm more worried about the criminal charge than against the good standing.
Yeah.
Medical boards don't typically, even internationally, don't take adverse license action against an individual until criminal charges have been fully litigated. There is an exception that you could add into it. I hate to overcomplicate this bill, to allow the board to waive that requirement for what's called non-cooperating countries, which is a whole sort of gamut that the department can decide which country is not cooperating.
Okay, thank you.
That's important not only for the criminal issue that you've raised, but if I'm leaving Afghanistan, it may literally be impossible for me to get my documentation out of that country because they're not cooperating with the U.S. government or U.S. Educational institutions right now.
Thank you. Thanks for that suggestion. You can keep going if you.
I was actually almost done. I was mostly
Oh,
going
yeah.
to be available for questions. I'd just like to thank the chair and the members of the committee for offering us an opportunity. Thank you for Senator Harrison for her leadership, and Diane and Ruth and the team. And we offer our very strong support for this legislation. I am certainly available for questions about what's going on nationally. Any changes you might want to look at, please dump on me.
I have a question around, how many other states did you say have?
Okay, 25 have 26 now have technically passed the bill, but
Okay.
most of those states require rule implementation before they can actually issue a license. So we are at the point where I believe it's 7, might be 8 now, states that have fully implemented our accepting applications.
Okay, has anyone completed in any
Yes.
of those other states?
They have not completed the provisionals yet because they've just started. But
So-
for example, in Washington, they've issued 50 licenses. In Tennessee, they've issued, I believe, 3, Illinois 1, Wisconsin 2, Louisiana 1. It's all very nascent now that the application process is in.
So if, for instance, someone was either in the midst of the process or they had completed the process in one state, then they would have a medical license to practice in that one state,
Yes.
which would then allow them to practice in another state.
Unfortunately not.
Okay,
The license portability is usually governed by the Interstate Medical Compact.
yeah,
The Interstate
was my
Medical
question, actually.
Compact only covers the traditional residency-based method of licensing. So this license is sort of outside of that. In theory, a person could move to another state and seek to be licensed through their endorsement process, but they're not eligible at this point for a compact license.
got it. All right, thank you. That answered that question.
Yep.
Are there any other questions? I have one more, but I wanted to give anybody else an opportunity.
I do know that earlier on the question of recency of service came up. I heard the tail end of Diana's comment. That is a challenge that many legislators face and spend a great deal of time on, is how old their practice history can be. The 1 out of 7 is frankly a pretty good standard. You don't want somebody who practiced 2 years, 40 years ago to be eligible for this, frankly, because medical education advances have gone on so far.
Yeah.
What I think is present in the bill, and I apologize if it's not, I think it is, it should say 1 out of 7 or another timetable if agreed to by the board. Because what's happening in other states, to be perfectly candid, is the hospitals are finding candidates, extending a bona fide offer of employment, and then working through the license process for that hospital. So if a hospital finds a candidate who meets their particular needs, particularly rural or otherwise underserved area in a high skill area, and they're willing to look at a longer recency, the legislation gives the board the authority to sort of waive that 1 out of 7.
Yeah, go ahead, Daisy.
Hi, Mike.
Hi.
I'm wondering, there is a suggestion from I guess it's from the Agency of Human Services, to take a little more time to establish qualifications for the provisional licensure, and kind of look at what other states are doing with regard to that. Can you speak to that suggestion from your background as a licensure aficionado?
Yes and no. I mean, what I think they're suggesting, and I just saw the amendment last night, is to have it either give more time or let the board do it by rule. My concern with rule is the promulgation process is long, it's cumbersome, it's not as inclusive as the legislative process. The other thing I would say is we are now at 25 states. Best practices have pretty much been developed. While there are differences among the states in terms of who the eligible hiring entity is, what the look back is, what the length of practice has to be, the criteria, ECFMG certification, a bona fide offer, passage of the USMLEs 1 and 2 to entry. Those are all standardized in those other 25 states. So I'm not exactly sure what the board would be looking at, in terms of looking at what other states have done, because Vermont, with a few exceptions, is following that model.
Thank you. That's helpful.
I think I had one last question, and this might be more of a, I'm not sure if you would be prepared to answer.
Uh-oh.
So first of all, I will just say, I'm shocked that this bill is in front of us because I'm trying to figure out over the course of history. I didn't know that there wasn't path licensure, which brings up like xenophobia and
Yeah.
American exceptionalism, as if our medical schools are any better than anybody else's in the world, but that's neither here nor there. So I'm wondering why
now?
well, not necessarily why now, but why not before? Where has been the pushback? And that also brings me to sort of a next question. I'm wondering what the various specialty boards, because there's nothing in here about a path to board certification.
Right.
And I'm wondering sort of where their standing is in this.
Yeah.
At all.
Those are two separate questions. Let me
Yeah.
ask the easy one first. Why hasn't this happened before? I think the depth of the workforce shortage is driving this debate. This has really been presented in most states as not how do we help immigrants and refugees utilize their skills and talents, but more as how do we utilize those skills and talents to solve our existing workforce shortage. And given the federal government's intransigence and increasing the number of residencies that are allowed, the workforce shortage has been exacerbated in many states like Vermont. You have an aging workforce in medical, particularly physician. So I think, in 2021, Washington did this. It worked, and other states have sort of gleaned onto it. It's part of a momentum. Why didn't it happen before? I don't think there were workforce drivers before, or certainly not of the severity they are now. If that answered that question.
Yeah.
I mean, honestly, I was licensing director, boy, I'm old, in the 90s. Never came up. I mean, there may have been discussions on, what occupational English test would we use, what certification entity would we use, but never any broader conversation about let's be creative and look at other pathways.
Yeah, I think I'm just sort of astounded at the idea that we would not maximize the talents.
Yeah. I agree 1,000%. On your other question on specialty boards, this is a bit tricky. Remember, the state has the authority to issue medical licenses, period. It does not have the authority to issue specialty designations. That authority is vested in a variety of national specialty boards. So what you're doing through this legislation is creating a pathway to licensure, not to a specialty designation. In most of those specialty designation boards, you are required to have an ACGME approved residency to even be eligible to get the specialty. And ACGME is US-based residencies. So until the national licensing boards do change, that requirement, it does not create a pathway to specialty designation. Now, there are a couple specialty boards that are actively looking at piloting this. Frankly, because of the number of states that are setting up licensure, they know they have to respond to this. The other thing I would point out, whether or not a hospital or an eligible hiring entity insists on specialty designation is up to that hospital, not to the state. So what we've seen in the states that have issued licenses so far, and to be perfectly frank, when this all began, based on what was going on in Washington, I think the assumption was that most of these ITPs would practice in general medicine, internal, family practice. While that's still the case in Washington, that has not been the case in the states that have issued licenses in the last year. They have issued licenses to individuals who practice in specialty areas without a designation. That's not illegal under state law. They often have to waive their bylaws or, work it through with their insurance carrier, but it is not prohibited. I mean, so there's a real tenuous link between licensure and specialty designation. I would anticipate as this program ages, there.
I'm sorry, can you stop for a second?
Yep.
I just lost my quorum.
Oop, I hate that.
I'm sorry if one more person leaves the room, I'll lose the quorum. And we have to stop. Thank you. You can keep
Yep.
going.
I was just going to say, I think as the program progresses and ages, the specialty boards will create pilots to do it. I just can't tell you right now that will happen.
Okay, thank you. Maybe Diana, can you remind us how many is it anticipated in the state of Vermont? How many people do you think we're even talking about here?
That would be applicants.
Yeah.
Well, I think I stated that the way things are now with the 3 out of 5 years, there would be none that we have interviewed.
Yeah.
Now, Ruth and I are aware that our outreach wasn't totally covering all of the possibilities, but from the 23 that we originally contacted and responded, and then the 16 we interviewed, if it's 3 out of 5, we would have no applicants.
Okay. But if it was
If
changed,
it's 1 out of 7, we would have 4 applicants.
4. Okay.
The other
But
thing to remember, Madam Chair, is this is really an attraction strategy
Yeah.
as well.
Absolutely.
The states that
That's
have
what I was
licensed
gonna
so
say is-
far have basically granted license to people who have moved to their state to practice.
Great.
Mike, can you,
Mhm.
can you help me understand why, if it's probably going to be so few people that we are adding to our practices, why the fiscal note on this bill has a request for 3 staff to do the work of licensing and review?
Wow.
You don't, I mean, if
I
you don't know,
hesitate
you
to
don't
criticize anybody. I think that's a lot.
know. Yeah, it seems high.
I mean, New York has had a system in place for decades. Now it's different because it's a pathway to full licensure that requires fellowships and a lot of other things. But they have licensed probably 80 to 100 a year for at least the last 10 years, and they use 1.5 FTEs for it.
That's helpful information.
Thank you. That is helpful.
But I'm always good on helping licensed people get more staff because they're usually understaffed.
That's because you said you're a
I'd like
licensing
to-
geek.
I just wanted to make one more comment, and it's because we're from Windham County, southern part of the state. There's an awareness, and Mike can comment on this, that the neighboring states that have much less restrictive recency and length of practice requirements, such as Massachusetts,
Mhm.
will really influence the number of applicants that come to
Yeah.
Brattleboro Memorial Hospital, that come to Grace Cottage. And so there's that competitive workforce attraction piece to this whole effort. That it would be so easy for that potential doctor to just go through the pathway in Massachusetts.
Mhm. In the same sense, I mean, you've got Maine's legislation is pretty much derailed right now. So there's a lot of people that were interested in Maine that would potentially move to Vermont. But you're also going to be competing likely with New Hampshire, who's got a bill in the final stages.
Thank you, and thank you both of you
Mhm.
for testifying today and joining us. Really
Thank you.
appreciate it.
Thank you.
I hope I can answer all your questions.
Thank you. All right, so let's move on. We're going back to 197 and we have Margaret Reynolds. Thanks for being here. This is the first time we've had you in the committee.
Yes, no, I appreciate it. I know you guys had your testimony yesterday.
Yes. And we had a little testimony this morning. We keep flip-flopping back and forth.
Well, hopefully mine is complimentary, but I am Margaret Reynolds. I'm with Cigna. I'm based in New Hampshire, so just a quick drive over. But my comments on Senate Bill 197 are really going to be focused on what we're already doing. Cigna is in the large group fully insured and also the self-insured market here in Vermont. We cover about 80,000 lives, and we do implore or we use value-based care to help drive our population to primary care. So that includes $0 copays for annual screenings. We certainly encourage our primary care physicians to do screenings and immunizations, and we reward our contracted entities for prevention of chronic diseases, management, and care coordination. So with that, we certainly encourage investment in primary care models, but we feel like we're already doing that. So our concerns with the bill would be if we were forced into a state structure, it might pull away funds from other services that we're also already covering for our members. We certainly think protecting employers from any premium assessments is important. We know health benefits are one benefit to attract and retain talent. We want to preserve voluntary participation in this to the extent that's possible. And what was the other thing? Oh, the other thing I was going to point out is that in the draft that was passed by the Senate, we didn't see any statutory limits on the assessments or how they'd be calculated. You know, that would be forthcoming from any reports or data that's submitted to the Green Mountain Care Board. So just want that to be considered as this bill moves.
Can I interrupt you for just a moment and ask a question? You said that you already reward for performance-based, I believe was your wording. How do you do that? What do you reward? How do you reward it? And what does that mean?
Yeah, that would be a better question for our contract folks, but I would be happy to follow up with the committee and kind of show what that looks like. I believe it's more tiered. So let's say somebody has diabetes, their A1C gets under control and perhaps drops. I believe it would be more of a payment to the provider for tracking of that and the disease management for the member. But I will double check on that and be happy to get back to you.
Okay, and also it when you get back to us, is that in the large group or is that in the self-insured? Or is it both?
Yeah, I will ask them.
Yeah. Yeah, I'm very curious about that. And to that same question, because of the unique position that Cigna has, which is, you know, you are in the large group market, however, you also are significant in the self-insured market. I'm just curious as to, I know that you pay into the Blueprint in your large group market.
Yes.
Do you pay into the Blueprint for all of your self-insured members?
I will have to follow up on that.
Okay.
Yeah, I will ask that. So it looks like I have a lot of follow-up for you. But the other thing, I just wanted to share for this committee's consideration is with the rural health transformation funds that will be coming into the state. In Maine, we've had conversations with the agencies who are handling those funds because they're also looking at not necessarily propping up, but assisting rural primary care providers and keeping folks in their communities rather than going to hospital-based systems. In Maine, it's mostly Portland and down east, but they want to keep folks in their communities. And part of the funding that they're considering, CMS put a cap of 15% being direct payments to providers, but really looking at transforming the system from fee-for-service to advanced payment models. And we're engaging in that process. So as Vermont moves, we would certainly like to support that and work with the state on that as well. Medicare and Medicaid are really fee-for-service focused, and it encourages the churn of patients, whereas value-based care encourages providers to spend more time with their members and to really look at whole person health. We think that benefits both the member and the provider, building that relationship, keeping them in their community, and we'd be happy to work with you guys as you kind of figure out where that money goes and how to help the system.
I think I'm a little confused.
It's completely separate from this bill, but I just wanted to point out the dual tracks and perhaps supporting a primary care system and other money that would be available.
You Cigna recognizes the benefit of a value-based payment system so that providers can provide comprehensive care without having to worry about the fee-for-service model. Does Cigna currently in Vermont, do they pay providers a value-based payment?
Yes, we have that structure. It depends on the plan and the employer-based coverage, but yes, we have a value-based model.
It would be interesting to know how many providers you actually pay a value-based payment to rather than a fee-for-service payment to.
Sure.
Primary care, that would be very helpful. I don't think we'd heard that before.
I think we do that.
Any other questions? Anything additional? Oh, go ahead, Wendy.
Could I, so we don't have any control over the what's going on with the money that's coming in from the federal. So what we do care, we care about everything. Is the blueprint, and we have no idea what the AHEAD model is, if it's even going to exist. I really am worried about the blueprint and the money that's going to go into, and the difference between the fee for service and the per member per person per. What is it? Per member per month payment? Yeah, I got it there. I just can't say it. And I totally respect Cigna, and I know that there's other services in the state of Vermont. It just seems like it would work so much better if everybody was doing this per person per. Yes, thank you. And it doesn't seem like it would be that much, but it seems like it would be so much. It would help your members too. I'm in a nervous that I feel like I want to contribute to it too. We all go to the same doctors. We all go to the same primary care doctors. And if we could all like build them up, I just think we're all going to win. Would Cigna be totally against like buying into the blueprint, do you think?
I'm not sure what, if anything, we do with the blueprint. I'm not as familiar with that, so I don't think I could comment on that.
Because my understanding is it would be a voluntary participation. I'm just wondering just how they would feel about it. Like we're a small state. I don't think it would be all that much.
We support voluntary legislation because it lets us weigh it and our
Yes.
plan sponsors weigh whether or not they would want to participate. So yes, if something is voluntary as opposed to mandatory.
Correct.
Yes.
Okay.
Yes.
Just throwing that out there. Thank
Okay,
you.
yeah.
Of the benefits through your large group and also through self-funded. Currently, right now in the state of Vermont, how much on average is Cigna spending on primary care? What percentage of total dollars spent is being spent in primary care?
I do not have that. I saw that that was a question asked yesterday and I do not have that answer, but I am going to track that down for you.
I just would like to say that I'm reading your written testimony. And I'm a little confused by, I'm a tad bit confused by the written testimony versus, sort of the blueprint in particular. You're concerned about the ERISA, that, you have if your self-funded employer plans are governed by federal law and states may not require those plans to finance or participate in state payment programs. This bill does not exempt ERISA plans, creating legal uncertainty and the risk of litigation, which also, and this is the part, while also encouraging indirect cost shifting to large employers that sponsor coverage for thousands of Vermonters. The blueprint right now, self-funded plans are cost shifting onto small group, individual, Medicaid, Medicare right now. That's the cost shift that's happening, not the cost shift that's happening the other way. Because right now, all Cigna members, all self-funded plans, it might not even be Cigna, it could be, name any, United, Aetna. All of those plans are not paying into the blueprint, but all of their members are benefiting from the services that the blueprint provides. I mean, that's where the cost shift is. So I just would like to point that out, that I think we are seeing a cost shift, but I don't think it's going in the direction that you're indicating in your written testimony.
Okay.
Okay. It would be great if we could have answers to the other questions.
Yeah, definitely.
All right. Any other questions?
I appreciate your time. Thank
you.
you.
Thanks for coming. Thanks for coming.
Yeah, no, I love it. I'm gonna go spend some money here. Grab some lunch.
We have taxes here though.
So we are
Happy to pay them for lunch.
We're done for the morning. We will be back here after the floor. We have 2:00, but I think they could be here a little earlier. So let's say 15 minutes after floor, because I think floor is going to be short today.